Okay, good morning, everyone. Can people hear me okay? Yes, great. And well, welcome to our next installment of our Neonatal NIRS Consortium webinars. I'm Valerie Talk, and I'm really excited about today's topic. Maybe just a few housekeeping things first, as we are waiting for people to trickle in. So again, the Neonatal NIRS Consortium, as you see here, is a group of us originally led by Jonathan Minster, myself, and Zach Bisola. And I've been so proud of how we've grown to now over 100 members that are now on the listserv. We put together these quarterly webinars, although we took a little break over the summer. And this is a really nice forum for us to get together to talk about all things NIRS related. I'm also really excited that Dr. Gabriel Altit was able to put together for us a website which has additional resources about NIRS. So I'm going to stop my sharing. I'm going to let Gabriel take over so he can show us a little bit about what this website looks like before we get started with the talk today.
Thank you, Dr. Chalk. Can you see my screen?
Yes.
So basically, the website is housed under this address, www.neocardiolab.com. And you will find here two ways to access the Neonatal NIRS Consortium. The first one is here on top, but there's also a main button here, Access the Neonatal NIRS Consortium portal. And when you click here, you will find the announcement for the next meeting, as well as the blurb related to the content of the next meeting. You will also find, you can either pass by this menu or here the buttons. You will find that there are the previous webinars, which are all hosted here under YouTube. And I think Dr. Vizoulis is on the line, and he's been putting it diligently on the YouTube available for the scientific community to be able to access these wonderful resources. So you can also just click on the subject of interest based on the table of content, and you can access to the previous webinars. If you go back, you have one section on the team, one section on NIRS articles. And as we're building more cases and we're sharing more information, there'll be examples of cases that are submitted for featured potential NIRS cases on which we can all learn from. So I will put the actual webpage URL under the chat. So please feel free to use it, as well as if you have any advice or suggestions of content to be submitted, you can always send it to me on my way.
Thanks so much, Gabriel. This is going to be a great resource for us. And I'll also send out the link to the listserv as well. And if anyone has ideas on what else they want to see on the site, or to help out with it, do let us know. Okay, so just a little bit about the format today. We have a wonderful speaker that I will introduce in a bit, but please remain muted and put your questions into the chat box. And at the end, we'll have some time and we'll help to moderate the question and answer session at the end. So without further ado, it's really my pleasure to introduce our speaker today, Katie Fedor. She is a clinical nurse in the neonatal intensive care at St. Joseph Women's Hospital in Tampa, Florida. And she's also one of the NICU nurses. I had the pleasure of meeting her at a small baby course given by Kathy Randall. And I was really impressed with how she and her team have put together a NIRS monitoring program at St. Joseph's and done a lot of great work also with some research that was spearheaded there. So Katie, welcome to our NIRS Consortium. Thanks very much for agreeing to speak today.
Thank you so much. It is such an honor to be invited to be able to speak with this group, and it's really been quite interesting. Learned many things from these webinars, so it's definitely an honor to be here and to just kind of chat about my perspective from the nursing aspect in the bedside and some of the things we've been able to do and are in progress in our unit. So, all right. I will go ahead and share my screen here. All right. So just let me know if anything looks off, or if you can see everything, and if you can see me, or if you have any questions, or if you cannot hear me, I can adjust things. So I'm going to talk a little bit today just about establishing a NIRS monitoring program in the NICU and sort of our journey in our unit. A little bit of a background for me, just so you kind of know where I'm coming from personally.
Katie,
yes.
Sorry to interrupt, but I think we can't see your slides, although we can hear you.
Okay.
Oh, there we go.
Is that better?
Yeah,
okay.
Yeah, perfect.
Okay, sorry about that. Okay, so a little bit of background about me and my unit. So as Valerie mentioned, I work in Tampa, Florida, at a level 4 NICU in called St. Joseph's Women's Hospital. We're part of the Baycare network, which encompasses several smaller NICUs and some level 2, some level 3s, but we're sort of the main center for level 4 babies. We have about 74 beds, and then we do share some space with our ECMO program with the cardiac intensive care unit. That's currently where our babies are housed that are receiving that type of therapy. But we keep all the babies in our unit that are undergoing cooling, awaiting cardiac surgery. We have surgical specialties, neurosurgical specialties, all of that. We aren't currently affiliated specifically with a university. So although we do participate in many research initiatives, we do sort of reach out for that. And I've invited Jane Solomon also to just kind of be here in case she wants to mention anything. She does a lot for our unit as far as connecting us with different quality initiatives and research projects. She got us involved with one of the big ones that we participate with is called the Florida Neonatal Neurological Network, the FN3. And that is a network of hospitals in Florida that participate in cooling and therapeutic hypothermia. And basically we come together once a year. This program was started out of University of Florida and Shands Hospital by Dr. Mike Weiss, and he sort of spearheaded this program and basically wanted to connect a network of hospitals in the state that provide cooling therapy and just sort of standardize our guidelines and kind of meet and share our data. So we participate in that program. We've been participating with them since 2012. And that's just kind of one of many ways we've been connected to different universities. We're participating in a probiotics study right now. So we do sort of outreach for that, but we're not specifically connected to a university. We don't have residents, fellows, and things like that in our unit. So our research is really hinges on buy-in from our staff and our bedside team to really get involved. And we do have people like Jane in our unit that really encourage people to get involved in different projects and things like that. So NIRS is kind of one of those things that we brought in when we began participating in the Neonatal Neurological Network and started our cooling program. It was data that they were requesting from us, and we had never done NIRS monitoring in our unit before. So that was how it was introduced to our unit. And then Jane and I attended a conference at Stanford for the Neuro-NICU training course. I believe that was 2016 or 17, and heard some lectures about NIRS that just kind of blew our minds, because up until then, at least from my perspective, still kind of just really gaining knowledge about cooling and all of the things that we do during cooling. NIRS was kind of the one monitor I didn't have to worry about. It was just data that we submitted to the registry. So it really opened up our minds about, okay, how can we move forward with utilizing NIRS in our unit, and what is it trying to tell us? And then also we've had increased collaboration with our cardiac team over the last several years, and just trying to provide as much continuity of care between cardiac units and our unit. So, you know, our goal is to provide them the same level of monitoring that they would receive there. We've been able to use it there as well. So, and also just a little shout out to Kathy Randall and her small baby program. We've kind of been utilizing this cube as a sort of reminder that everything we do in the NICU sort of affects everything else. So NIRS is a really good way to just monitor these babies a little more closely. And I know that visual is a really good reminder for our team to just sort of make sure we're always trying to put all the pieces together. So the course objectives I have today are just kind of to identify different ways that NIRS might look different for different populations. Identify ways to incorporate NIRS into your assessment, and some things that we've kind of discovered, some things on purpose and some things on accident. And then identify a situation where NIRS monitoring has provided important clues to the status of a fragile infant. So again, these are kind of the top 3 ways that we utilize NIRS in our NICU. The first being what I mentioned previously with our initiation of our therapeutic hypothermia program. We began monitoring infants with congenital heart disease that are staying in our unit longer. We used to kind of ship them out right away. Now we keep them a little bit longer. So again, just trying to provide them the same level of care they would receive in the cardiac unit. And then recently, a few years ago, we began monitoring preterm infants before, during, and after PRBC transfusion. And this was kind of a program that really ended up being quite detailed, and the way it was rolled out kind of really helped our nurses to understand NIRS a little bit better with some really inclusive flow sheets and things like that, lots of education. So I'll be focusing on just ways you can really engage your team into learning about NIRS and really getting them excited, because it is a vast area of knowledge. And I feel like we're just kind of at the tip of, learning what is to come. So I'm excited to see what we might learn from NIRS in the future. What we're hoping to bring into our unit with NIRS, and we're just, again, just really excited for some of the research that will hopefully come out. We can start utilizing this in different ways, is really any infant on pressors or inotropes requiring high ventilatory pressures, infants with hemodynamically significant PDA. We've learned a lot to sort of, like I said, on accident monitoring infants for other reasons. And then paralyzed infants, we certainly believe it can provide us clues to what might be going on with their sedation levels. And then infants with CNS abnormality or seizures. So I wanted to introduce you to our flow sheet that we brought into our unit. This was the project that we began a few years ago based on a study that had come out, which actually there's even new data since this has come out, but we started to really relate gut injury with PRBC transfusion, and we wanted to learn more about that. And there was a lot of data being presented to us that that NIRS might provide important clues to gut perfusion during and after transfusion. And so this was a flow sheet, and this is probably edit number 5 or 6. I mean, this is a project we rolled out, and then we very quickly started to tweak it based on the information we gained from the staff. Really, one thing we've really discovered more than anything else is anytime we roll something out in the unit, definitely staff feedback, we're kind of learning how to be really responsive to that and change our tune quickly if we need to fit the needs of our staff and make it really useful, so that they can apply it to their patient care and make sure that we're monitoring, we're gathering useful data. So what the way we formatted this project, so we decided, because at first we didn't really have a supply of NIRS monitors to really monitor every baby that we wanted to. We're slowly still increasing that in our unit. So at the time, we only had a few monitors that we just sort of happened to have for cooling infants. If we didn't have a cooling infant, we had them available. And since then, we were able to obtain a few more. But we don't really have the monitoring capacity in our unit right now to monitor every baby. But we do know that there was a need to kind of gather some sort of baseline data for infants before making decisions based on their NIRS. So the way we sort of targeted our monitoring in the beginning was we would put babies that were identified as needing a PRBC transfusion, So we'd have our physicians put in an order the previous day, sort of worded as, either they would obtain a hemoglobin and hematocrit in the morning or CBC, or just go off the blood gas. But the order would then read, if hematocrit is below a certain threshold, apply NIRS and make infant NPO. So that was sort of our first stage. And that would sort of allow the nurse to begin this 3-hour monitoring period the next morning, sort of as the doctors were coming in for the day. And then they could go ahead and order the blood transfusion and the things that were needed. So we allowed the nurses we encouraged them to really monitor trends, but we decided on an every 30-minute spot check of the NIRS at first. We kind of know these absolute values are very important to bedside staff. So we knew it was important to have them sort of notate these every 30-minute values. We had them obtain a somatic reading and a cerebral reading, so either side of the forehead for one probe. And then our somatic readings at first were all placed on the periumbilical area, which I'll go into a little bit further. We found that to be a little problematic and had some issues with reading in that region, but we did decide for some of our smaller babies to go ahead and place the second probe in a renal or a splanchnic site. So we had nurses collect every 30-minute readings, the somatic and the cerebral, and I did encourage people to, these were premature infants, so some of our inclusion criteria was that this had to be a baby that would naturally, at this time, and with the data that we were using at this time, require NPO status for transfusions. These were our babies that were adjusted less than 34 weeks on more than trophic feedings that were being screened. So a lot of these infants were still a little bit, up and down on their SATs and a little back and forth on their oxygen, maybe not the most stable babies in the unit. So I did encourage nurses, if the baby's satting 70 at one point, not to record that NIRS value, but rather try to always record a value where the baby's around satting in an appropriate range, so that we sort of had some continuity of our readings. And then we would actually have the nurses calculate the cerebral somatic ratio. And that kind of told us that, one calculation is important, but the way they related to each other is much more important. If we notice that both readings were dropping, is more often related to desaturation. But what we were really looking for is a situation where the cerebral would be maintaining at a certain level, but the somatic would be dropping. So we're really trying to get nurses to focus on how are these two numbers relating to each other, and that was the reason for calculating the ratio. At the end of the 3 hours, we would begin the transfusion, and we calculated all of the ratios and gained an average. And so this sort of became our goal for the baby, to return to this average or this baseline after transfusion. So this kind of set the tone for the baby's future plans for returning to feedings and things like that. So we recorded hourly readings throughout the transfusion, and then for 4 hours after, we were maintaining all babies NPO. And that's really where we watched that after this reperfusion, this blood transfusion was provided, we wanted to make sure that this sort of like rapid transfusion reperfusion injury did not occur. And there were some other things that we adjusted at the time related to our protocols. For example, this was a few years ago when we had sort of really tight transfusion guidelines, and since then we've opened them up a little bit based on the latest research. But at the time we had pretty high thresholds for transfusing, pretty low thresholds for transfusing. So a lot of these babies weren't terribly anemic when we were monitoring their baselines. What we've noticed now, since we're allowing that threshold to be a little bit higher, we do notice some lower readings prior to transfusion. But we would encourage these babies, we let them rest. We watched them for the 4 hours post-transfusion. We really wanted to see them return to their baseline to start feedings. Once we restarted feedings, and as long as the baby looked well and the NIRS was reading appropriately, we would restart feedings typically at full volume to where they were before the transfusion. Where the NIRS has kind of helped us is we decide whether or not we need to adjust that a little bit, start them slower, start them at half volume, things like that. So this was our flow sheet. And again, like I said, we had to adjust it several times just based on some of the things we decided that we were important to our team and information gathering, and just some from the feedback of the nurses. So this was our flow sheet, and this is just an example of some of the things that we would see during transfusion. I will say, because of the adjusting with the lowering thresholds of the hematocrits, we did not see a lot of babies have issues with gut perfusion and gut injury during this time. But this is a really good example of a baby that I found quite interesting. We monitored during the pre-transfusion period. And as you can see, the values are a little on the lower side for the cerebral and the somatic. This was a 27-weeker. I believe he was about 2 weeks old on high frequency ventilation that was on full fortified feeds of mom's milk. Feeds were held for the PRVC transfusion. This baby did have sort of a baseline abdominal distension, and this was a baby that we monitored our somatic NIRS on the renal site. So as you can see, this baby responded quite well to receiving a blood transfusion. You see both values had a rise. And then you see the cerebral kind of held at that nice new level, maybe even borderline a little bit high, possibly just needing maybe some weaning on ventilator settings or something like that. But then if you watch the somatic and what kind of happened there, the baby maintained a nice higher reading on the somatic and then sort of dropped off towards the end of the transfusion, and certainly during that last 4 hours of monitoring. So this is a baby, you know, we huddled as a team, and our physician that had this baby, you know, kind of pulled us in, and we had a good chat about, you know, what's our plan for this baby. So our first, you know, idea is always look at the baby and assess the baby. He had not required any more oxygen. He was well appearing. His color was good. He wasn't giving us any signs that he was in any distress. We did obtain an abdominal x-ray just to sort of make sure we were keeping an eye on things there. And then the decision was made to sort of hold off a little bit longer on returning to feedings. We waited an additional 3 hours to return to feedings, and then the baby was started at half volume for a few feeds and then advanced to full volume, and the baby did quite well. Never developed any issues. But this is just sort of a baby that, you know, we like to think that we prevented something potentially more devastating like a gut injury in a baby like this. So even though I will say we didn't see a whole lot of babies that had this response, you know, it was reassuring when we did see that we were seeing some of the things that we sort of had read about in the literature. So I will talk about some of the other things we've learned along the way. So I will talk about the small baby, and we've recently in our unit initiated a small baby program. This was some of the information that we kind of pulled together regarding sort of the differences in a small baby to a full-term baby. I won't go into detail here, but these are the main things that we look at and when we're comparing these two populations. So, you know, certainly in my career, and I've only been a NICU nurse for about 16 years, I've seen a lot of changes in what we're asking of small babies. You know, it used to be sort of, we kept them on TPN for a long time. We kept them on high frequency ventilation. And now there's, you know, a lot more pushing towards full fortified feeds, using less ventilation. And, you know, when you look at it all together, it does seem like we're asking a lot more of them early on to sort of achieve some of these better outcomes that are related to, you know, some of the dangers of not providing this less invasive ventilation and full volume feeds. So it's critically important when we're doing this with these small babies that we utilize every assessment tool we can to ensure they're progressing and thriving. We would love in our unit, and I'm sure Jane would agree, that we would love to see every small baby on the NIRS monitor. And we're hoping, you know, as research comes out and we get better values for these babies, that we're certainly able to do that. So we look at the big 5 sort of outcomes for the small babies. We know that these are the things that we're constantly striving to achieve, benchmark and certainly better outcomes in regards to all of these aspects. So, we keep asking ourselves, and we continue to ask this question of our medical team and our quality team and research team, that can we come back to NIRS and can we use trending in all aspects of our documentation and our assessments? But certainly there's a lot of us that are just really eager to get NIRS on these babies, and we know that it's trying to tell us a lot. So, one thing that we encourage of our team consistently, even though, as I mentioned before, we place a lot of value on sort of these absolute values that we chart. Documentation certainly is important, but we really emphasize to our team the importance of trends. And with NIRS, that seems to be really of utmost importance for especially the small baby population. So one thing, we keep sort of questioning these things and trying to look at them differently. And, we've had a lot of good dialogue with our bedside team and our nurses regarding, how can we make a trend an absolute value, and how do we make it valuable? And we've started to look at other areas of medicine that are documented and assessed using trends. And as you can see in this picture here, this just kind of is a visual reminder that, even though this baby might be reading 85 and 85 at two separate hourly intervals, certainly what both of these lines are doing is very different. So this is one thing that we just continue to impress upon our team, that while yes, it's important that we document absolute values on the hour or whatever our protocol is for that certain population, that we really pay attention to what our trends are trying to tell us. So we started to talk about, what are the things we look for with NIRS? Well, we look for baseline and we look for variability, and then we certainly want to know what's happening to the baby during an event. If the baby had to be reintubated. We had a couple of our babies that just so happened to need intubation during their monitoring for blood transfusions. And it really was enlightening to see what their NIRS values did during events like that. So we tried to think, okay, what other areas of medicine really monitor closely baseline variability in events? And one of the things that sort of kept coming up, a lot of our team goes to deliveries. And while we're certainly not experts in fetal monitoring, we sort of found it interesting that you could almost relate those two categories to each other. It's another area of monitoring in medicine where you're looking at baseline, and baseline is important. Variability is certainly important, and events are important. So this was just sort of a little incidental thing that we came up with in the NICU, like, maybe we categorize fetal tracings. Maybe there's a way to categorize our NIRS values, because even though we did have these excellent flow sheets that really people were very good about asking questions, and then nurses were excellent about communicating feedback and things that they discovered, there is a lot of times where your assignment is busy and there's a lot going on in the unit, and you really are just jotting down that absolute value. So we thought, is there a way to make our documentation related to this project more trend-based? So this is something that, I would love to see sort of come to fruition in our unit. But this is just another example of how I believe the two are related. And, I'd like to sort of think of NIRS in the same light. And certainly when we're discussing NIRS values in interdisciplinary rounds, I sort of say, yes, there's a concerning tracing rather than just communicating absolute values. So you look at, you sort of can compare variability, and certainly know that more variability and possibly less variability is not necessarily a good thing depending on the status of the patient. And then this was a chart we sort of just put together. Again, this is just sort of my brain dump and just kind of trying to take notes and trying to make these two things relate to each other in a way that is helpful and useful. But to look at NIRS data in sort of categories, and would that help us in the future to look at these babies? Because while we know the nurses are able to see these things, sometimes we really wanted to consistently provide the same level of monitoring and surveillance. So this was just something I sort of had written down based on the most current research and what's happening with the variability in the baseline and what happens to that baby during events. Okay, so now I'm just going to go through some case studies from our unit and just some things that we, again, we're specifically monitoring for, and then some incidental findings that we found were very interesting. And these are things that, we really put these into light when we had a nurse that really, dug deep and looked into this NIRS findings or, whatever occurred in the unit. We really impressed upon it. And Jane does a wonderful job of this in our unit. If we have someone that's really looking deeper into things and, we put them right up front and we give them the spotlight and give them the opportunity to really discuss and share and specifically with the whole multidisciplinary team, whether it's in rounds or, we're certainly encouraged as a bedside nurse to discuss what we find, even if it's maybe not what we're looking for. And, encouraging nurses to really think, and we feel like our nurses actually became experts in our NIRS monitoring quicker than, some of our physicians did, even because, they're there monitoring constantly and they were able to learn a lot. So what we thought was going to be a very overwhelming thing to introduce it to our unit, actually, we found that we have a lot of really good champions for this project that became really interested. And certainly when you see things that you may not be able to catch otherwise if you didn't have this monitor on, it certainly drives home the importance of this monitoring. So I'll bring up case 1, baby A. So this case involves a baby that we had in our unit actually just prior to beginning the NIRS during transfusions project. And we, like I said previously, had only had NIRS monitors on babies that were participating in our cooling registry. So this was really the first time we were going to put NIRS on a smaller baby in our unit. And also we just kind of wanted to know before we introduced this whole project to the staff, is this safe? What are the considerations we need to make with the skin and probe adherence and does it pick up well on this population and things like that. And I happened to have an assignment in the unit that day. I had a lovely little 28-week infant who was very stable, 7 days old. I said, he would be a really great candidate. He does, it's a little drifty on his hats, but he's very stable. He does have this PDA. It'd be very interesting to see, what his NIRS look like. So his skin was in great condition. He was a good infant to trial this on. So we put the NIRS probes on him. He had, so his history here is he was 7 days old, male, 28-week infant. He'd been on CPAP from birth, was on +5, about 25%, like I said, very mildly drifty, on occasion to the high 80s, low 90s, but was pretty stable on his oxygenation. Did have a large PDA which was found by murmur with bidirectional shunting seen on echo. In other history, he had a grade 1 IVH, was on no sedation, and was alert and active. He was on full feeds of donor milk, 22 calorie. So we placed the NIRS monitor on him just sort of to do this mini PDSA in our unit and just make sure, we don't need to know anything more about these probes before we roll this out. So this is what we found. And this NIRS pattern was quite interesting to me because first of all, there was definitely a little bit of what we saw, cerebral protection when he would drift down a little bit. You see that his renal site would plunge a lot further than his cerebral site. But also these were just very mild desaturation. So these were just his drifting to the low 90s, high 80s that we would see these sharp decreases in his readings. And then also, we noted that his baseline was quite high. So, as nurses, I can say that a lot of times, you have a baby that's very drifty, you keep them on slightly higher oxygen or less drifty. But we also try to be very studious with our oxygenation. So this is a baby that may have not necessarily needed that 25% all the time. But again, this was just sort of a mini PDSA to see, what we could learn from NIRS and will it work on this population. So we found that this was quite interesting. But again, this was just a short little trial, sort of preparing us for having this program roll out. So 5 days after our little mini PDSA in the unit, and before we had begun our formal rollout of our NIRS during transfusion program, he received a blood transfusion. He was now 12 days old, very stable again, still alert and active, still had a murmur, still a little bit drifty on his stats, but not really, no change in his clinical status. He was not made NPO because again, we were just sort of on the precipice of making that change. So within 48 hours of his transfusion, he began to show signs of decomposition, which prompted a septic workup abdominal x-ray. His initial KUB showed pneumatosis, which quickly evolved to free air as we were beginning antibiotics, gathering information, getting surgery involved. I believe by the time surgery came to the bedside and we repeated that x-ray, he had free air. He was immediately prepped for emergency bowel resection, was determined to have neck totalis with only a small bowel of colon, a tiny amount of small bowel and colon remaining viable. So this was quite poignant to us. Of course, this is a baby that we're never going to forget. I mean, we were right there with the information, and to see something like that occur sort of right in front of our face was quite sobering. And he is sort of the face that I see when we roll out projects related to NIRS and trying to protect these babies from gut injury, because we all know how devastating that can be. So, you know, we asked ourselves these questions. Was his PDA playing more of a role? He did receive 1 round of Tylenol, but continued to have this seemingly hemodynamically insignificant PDA because it wasn't truly affecting his clinical status, but maybe NIRS was trying to tell us that it was. Could we making him an NPO for transfusion, and then overall just using continuous NIRS from the start on him, could that have helped us to adjust our care for this baby? Okay, so moving right along to case number 2. So this was a baby in our unit who was 24 weeks old, AGA male infant, now 27 weeks adjusted, on jet ventilation with an FiO2 anywhere between 40 and 70%. This was a baby that was quite unstable and had a history of traumatic home delivery, the grade 4 IVH, was on a fentanyl drip, had a PDA that was closed after a course of Indocin, no evidence of pulmonary hypertension, was on full enteral feeds of donor milk 28 calorie, and had a PIC just for sedation. So we placed the NIRS on this baby for his NPO for transfusion flow sheet. And we discovered that our readings were very difficult to sort of comprehend. And this was unfortunately sometimes what we would see, putting the NIRS probes on these tiny babies. We would have readings that even though this baby had a very varied oxygenation status, it still just seemed sort of dramatically low for his clinical presentation. And these are the babies that, you know, we would sort of troubleshoot using new probes, different probe placement and things like that. But it ended up being kind of tricky to monitor some of our very small babies. Certainly if there was an element of abdominal distension, or certainly this IVH with a little bit of hydrocephalus played a role into where we placed our monitoring probes on the forehead. So, you know, even though we had some probe issues from time to time, we still continued to monitor these babies. His reading eventually did sort of correct into a normalized level throughout his blood transfusion. And then these were just conversations we had. You know, we would tell the physicians when we huddled, you know, that we had monitored the baby for 3 hours prior to transfusion, but we do feel like there was some element of just not being able to capture a proper reading, whether the baby was just too small, had some sort of artifact that was affecting his reading. So those were all conversations we had, but the baby did eventually throughout his transfusion come to what we would expect more of his readings to be. We didn't see that 15 anymore. It was sort of a more normalized reading. Baby was made NPO and given his PRPCs. And in the post-transfusion monitoring period, things were going sort of as expected. His levels were returning to a normal range for what we consider for that gestation. So the nurse discovered that, you know, she had him on his belly, he's gotten his blood, he's resting really well, he had sort of a calm day, that she was able to wean very quickly on his oxygen. And we've seen this many times in our unit. Our babies that are sort of have sort of a troublesome 24-hour period and then start to improve, we put them on their bellies, we make these changes, and we're able to rapidly wean their oxygen. And typically we've always gone off the pulse ox monitoring for that. The nurse called me over and said that, you know, I'm not sure what's going on with my baby. You know, I know you helped with this NIRS project, so I just need your help. You know, I was able to go actually all the way down on his oxygen, back down to 45%. He's doing really well, but all of a sudden his NIRS values have dropped. And so, you know, we just had a really good chat about how, you know, potentially even those oxygenation is saturations may be able to recover from a rapid wean in his oxygenation. Maybe the NIRS is trying to tell us that that was a little too fast for him. Or maybe we needed to find the happy medium there. And where this baby ended up being just about 5% higher than where she had weaned him down to, we had a good saturation that wasn't too high, as well as a more reasonable NIRS reading. So I think that was definitely one of those moments, and we've had so many of them in our unit where our nurse is like, oh my gosh, she kind of said to me, you know, is this what's happening every time I rapidly wean this baby down? Are we taking these babies too far just because their stats look good? And you know, to me, it just made me happy because it got us thinking about it from every level. And I think NIRS has definitely been one of those things that we've seen over and over again. The nurses making these comments like, well, I had no idea that the oxygenation level or the perfusion level was really that, when, you know, previously all we had to go off was our stats. So again, this was the #1 comment we received from nurses, that many times when one of us would get called over to the bedside for a low reading, it was, and you know, that is one way also we sort of ruled out probe failure. I said, you know, if you turn the baby up a few percentage points, does the NIRS recover, or is it sort of stagnant in this really oddly low reading? Maybe we need to adjust the probe. So just making that connection between oxygenation and saturation in NIRS readings was really gets nurses, I believe, to get truly bought in and make them champions. Now, these nurses that have made these discoveries are all, you know, of course, Jane is very good at pulling them in and making them champions for, you know, whatever our next NIRS project may be. So one more case study I have here. This is baby B. It's a term female infant undergoing therapeutic hypothermia on day of life 2. This was a baby that just kind of barely made it into our therapeutic hypothermia. So she's on the milder side of HIE, but was considered moderate enough to be cooled. AEG was initially discontinuous, is now continuous normal voltage with sleep-wake cycling. So she's on day of life 2, doing quite well on a Precedex strip for sedation, a fairly low to moderate dosage of that. Respiratory was just getting 2 liters at 21%. And cardiac-wise, other than a low resting heart rate, had no signs of PPHN and no cardiac issues. So we found, and this is another common thing we find with our, especially for some reason, our milder, we don't cool mild babies in our facility, but our babies that fall on the milder side of moderate, that are undergoing therapeutic hypothermia, we use Precedex quite regularly, but we do find that sometimes these babies require a little bit more sedation because they tend to be a little more active, and especially after that first day when they're not stunned anymore and they're starting to feel a little better. So they require a little bit more titration upwards on their Precedex strip, and then we start to see that side effect of a low resting heart rate. And oftentimes we might filter in a PRN and work our Precedex down a little bit, but I had the nurse come over and ask me about the low resting heart rate, occasionally dips to the low 70s, and then as the day progressed would start to dip into the high 60s, which is definitely outside of our limits of what we consider normal. So again, we huddled with a provider. We brought everyone over and we said, let's really look at this baby from all aspects. Again, that little NIRS monitor that was in the back that we used to only submit the data to the registry. What is that trying to tell us? And what we would find was we were kind of going through this cycle with this baby that if the heart rate dropped, we tried to wean the sedation and then she would get agitated and we tried to go back up. So we decided that instead of sort of going all over the place with this Precedex strip, we might filter in a PRN, but then also, the RN actually mentioned it and she said, well, I noticed when the baby hits this certain heart rate, we see a drop in the NIRS. We start to see the NIRS drop down. So maybe if we set our alarm limits and set our goals to, I believe it was 70. It was a little lower than we normally go. If NIRS is telling us that's safe for her, are we comfortable using that as a guideline? And so I was super proud that that was brought up as just another tool and a way to assess this baby before we keep going around in circles with the sedation. And potentially we had even talked about turning her blanket up by a little bit. Just to kind of help keep her heart rate into a more acceptable limit. So we did obtain an EKG and that was found to be normal, just bradycardic. So this, between using the readings to alter our limits and what we were comfortable with her heart rate being, and then adjusting the sedation a little, we were able to sort of maintain this more consistent rest and comfort throughout the remainder of her therapeutic hypothermia. And I think that is all I have. I will open up to questions.
Katie, that was a great presentation. Thank you so much. We really learned a lot. I think maybe I'll start us off and then we'll please put your questions in the chat box and Zach and I will moderate. But I'm just curious, from your perspective, what were the biggest challenges to implementing a NIRS monitoring program in your unit?
So I would say, and this was one of the first projects I really heavily participated in the education portion. So Jane was presented with this, the project from our neonatologist staff. They really wanted to address our gut injuries related to transfusion and wanted to use NIRS to do that. So we were tasked with educating the staff. And I think the biggest challenge for us was trying to come up with, education with staff is always a challenge. Every year we seem to always put out this, how do you like to be educated sort of surveys. And it seems to be very split. Some people like an email, some people like an in-service. And so we really knew with this, we absolutely could not roll something like this out until everyone was a little bit comfortable with NIRS. We really had to catch the whole team. So we did a lot of education on wheels and personalized conversations and just tried to catch every single person coming in on different shifts and really giving people an opportunity to ask questions. And we found that even though some people preferred an email, for their education, it was really important that we do it in person so that people can ask real-time questions. The biggest challenge for us was trying to come up with a one-liner to explain NIRS. When we are doing education on wheels, which we determined was the best way to connect with everybody, you're very challenged with times. Nurses have busy assignments, and we wanted to talk to physicians and respiratory therapists. We really wanted everyone to be involved. And that does mean that you have to sort of catch people in their downtime, which isn't always, you don't always have a lot of time for that. So trying to come up with sort of a one-liner just to explain NIRS, because I think when you're just brand new and learning the concept and trying to learn how sometimes it's inversely, related to perfusion and, there's not always, especially with premature infants, a specific, normal. And so trying to sort of come up with, shorthand education to quickly make it easy to wrap your brain around was really tricky. We had a lot of people that were like, okay, I think I got it. And they would ask a question and we'd be like, okay, let's start from the beginning again. So I think that was the biggest challenge, was trying to really shorten our definition of, what is normal and how do you relate NIRS to perfusion and oxygenation.
That's great. And was it just you, or was it like a designated team? Like how big was your educational NIRS team that was able to, go about teaching people or talking to people?
So at first it was Jane and I, and then we did enlist our educators at the time to sort of help reach out to people because they had used NIRS in other units. And we did have a couple nurses in our unit who had used NIRS before. We did ask our cooling nurses, we have a dedicated cooling team to sort of help these super users. But again, we weren't really using that information a whole lot before this. So a lot of them were really new to it as well, and hadn't really paid much attention to those numbers prior to starting this. So at the beginning, it was just a couple of us. And then, like I said, when we captured someone who had sort of made this discovery on their shift, we used that. So, you know, we sort of put them to work and said, okay, now you're a super user. Like, you get this enough to relate it to your baby's assessment. And people were excited about it, especially when they felt like they caught something. Because that's what we all want. I mean, we want to be able to capture little changes in our patients way before, you know, the major changes occur. So in the beginning, it was just a couple of us, and we do have a staff of almost 200 nurses. So it was pretty tricky, but we did feel like it was really important for us to be able to really explain it well and be able to answer questions. But again, it was just something that we tried to truncate into this like short little 10-minute, you know, at the bedside. A lot of times it took even a couple times of coming around, and certainly finding that time on night shift, especially when people aren't just too tired to wrap their brain around the concept. And but we did eventually get to everybody, and we still get lots of questions. You have a lot of new staff that come in, and the huddles when we do find something are incredibly valuable. So we can't always make those work if there's a lot going on, but we try really hard to make that okay, let's pull in as many people we can to this conversation so we're all learning something. So
that's awesome. I think Jonathan had a question.
Oh, hi, this is Jonathan Mincer. Catherine, I'd like to start out by commending you on an excellent presentation, very informative cases, and your entire approach, I feel, represents a sort of the early stages of a new state of the art when it comes to how this monitoring system can be used. That yes, the ultimate goal is that the bedside nurses will be able to make determinations and determine that something at the bedside is just not normal, that, you know, a baby is drifting away from what our normal expectations of normal behavior would be. I'm also absolutely enthralled that the idea of variability has entered the picture. This is something that has gone on for the better part of a decade now, as to whether absolute values versus variability versus signal behavior is the most important finding when it comes to near-infrared spectroscopy. So I commend you on that. And the question that I have is, are you saving your data on the individual babies? Because I believe if your nurses with their advanced level of experience now can team up with other nurses, perhaps around the country, perhaps using this consortium, the data that you're putting together can probably eventually tell the final story as to whether values versus variability are the ultimate outcome. So whatever your ultimate plans are, keep it up. I think what you're doing is amazing. And I hope that you carry these ideas through to as your career advances and you find ways that you can determine how this signaling, how these signals can actually be used to improve care of babies. So really my biggest applause on your presentation today and what you're doing over there. I think it's amazing.
Oh, thank you so much. I 100% agree. I think, you know, us as a unit joining the FN3 and how we were able to network with all the other hospitals in the state of Florida and come back together annually and share our data. I mean, that was tremendously helpful to us as a hospital. So I can only imagine what something at this level could achieve if we are all able to share our data. We are trying to capture as much as we possibly can. And I think a lot of it does have to do with sort of the technical aspects of it. I've tried to work with our technological team to sort of gather these the data as much as possible, because again, we have these flow sheets with the absolute values, but what I would really like to see is sort of a large case file of our actual trends on, you know, a flash drive or whatever that might be, so that we can go back and review them, not just as little, you know, screenshots on our phone. So we're working on that and just sort of like interconnectivity with our medical record and trying to trying to see how we can collect that. I think I've learned a lot of how through this consortium of how other hospitals are doing that as well. So I think the gathering of the data and the sharing of the data is something I look forward to in the future. Because I think we have so much to learn, and I'm very excited about it. So thank you.
And then I was going to summarize. There have been some really excellent questions in the chat here. I wanted to summarize a couple of those and see what your responses were. So one question was about skin integrity, especially for the little babies. What approach do you guys use?
So we typically, I will say, by only monitoring babies that were outside of the trophic feeding period, we avoided that initial, I would say at least 3 to 5 days, first days of life when our babies are super, super fragile. But we certainly did have some babies that still had fragile skin at the point that they were ready for NIRS monitoring. I will also say we made the 23 to 27 weeker. Our goal was to monitor them with NIRS, but we also weren't always making them NPO, and we did exclude a couple of our very tiny babies just based on skin integrity. And we found that a couple of our very, very small babies, we had trouble obtaining useful readings. So of the babies we monitored, we had very few issues. Certainly of the babies that were a little bit bigger, we didn't notice any skin integrity problems. And I will say on our cooling babies as well, so we know they're extra fragile with the being cooled down, their skin seems to do quite well. We haven't had a baby that has had a problem with skin integrity. But we do rotate sites on our bigger babies. And then for this particular project, the total monitoring period is only about 12 to 15 hours, depending on how quickly they return to full feeds. So again, that was another, we would love to do continuous length monitoring, but we were able to just put the monitor straight on the skin, and we had very few issues with skin integrity. And again, like I said, it was those babies that we identified before we even started as having just that very severely broken down skin. We refrained from monitoring. Those babies fell within that. They wouldn't have been eligible to be NPO based on the current protocol anyway. I will say through the small baby program, Valerie provided us with lots of useful tips for monitoring. We've been able to successfully place probes a couple times now, just sort of preventatively, and to make sure that we can sort of trial and make sure it works. But we started using Mepitel, a Mepitel product under the NIRS probe, and that is an option. Our probes seem to work very well through that. Another thing tends to be we were trying to reuse the probes, and we worked with the reps a little bit, and we were kind of told they could be reused. Because again, we're only using them for a short period of time. So if they wanted to be reused for multiple transfusions. So then what we kind of started to run into was securing the probe once it wasn't as sticky. So then we had to sort of go back to trying to use different types of silicone tapes and things like that at a very minimal amount to try and keep them adhered to the surface enough to get a reading without breaking down the skin. But I will say more often than not now, we just go ahead and get a fresh set of probes. And then certainly once we move towards more continuous monitoring of preterm infants, our term infants get new probes every 24 to 48 hours. Then our preterm infants are probably going to be doing about the same thing. We won't have that issue of what we have to use to sort of secure it. But underneath the actual probes and lights itself, we haven't had really any issues with our skin integrity, but Mepitel was presented as an option to us at the small baby course, and we have found that it does work, and we look forward to trying to use that on some of our more fragile babies.
Yeah, and we've had really excellent success here with that as well. There's a really, for those that don't have the chat open, there's been a really nice discussion in there. Lots of people sharing with what they do with their individual institutions. So that's great. One question that came up earlier, and Dr. Hare put a nice link for a paper that just came out that I thought was a great one I saw a few days ago, about using the NIRS monitor in conjunction with the pulse oximeter to make decisions about FiO2 weaning. Is that something you guys are routinely doing now? And could you share a little bit about if you have a specific protocol or what people have been doing?
So currently we don't. A lot, and again, like I said, this is a short-term monitoring of these babies. So I believe that when we do move towards more, hopefully more continuous monitoring of our preterm infants, that'll be something we utilize into our clinical standard, because certainly I think the two need to sort of agree in order to make those changes. But the babies that we do continuously monitor tend to be more on the cardiac side. A lot of our cooling babies, we have sort of on high alert for PPHN. And so we're already letting them be a little hyperoxygenated. But it is a really good tool to use trying to balance, that oxidative stress to the brain with, with trying to maintain an oxygenation that's helpful in preventing PPHN, pulmonary hypertension type issues. So, I will say, I think our cooling nurses, certainly since we've started using more NIRS on other populations, have really started to hone in more on what the NIRS is trying to tell us during cooling as well. But it's usually more of a conversation with the whole team that we discuss in rounds, because those term babies aren't babies typically we're adjusting the oxygen a ton, unless they're really unstable. But we try and keep them more at a stable threshold that keeps them, their PaO2s and that sort of thing, in a happy place. But I think it's definitely something that's important to write into a clinical standard if we start to use it more continuously on the babies that are really drifty and labile on their SATs.
Great.
Well, it's already the end of our hour, but we had a lot of great discussion and questions. And Katie, this is just a wonderful talk, and I think got us all thinking. So thank you again. We will be distributing the link to the recording to everyone, and we look forward, if you have other ideas for future talks similar to what Katie has given, just let us know. So thanks so much, everyone. Thanks again, Katie.
Thank you so much.
Thank you.